So good afternoon, everyone. Welcome to our lunch and listen session. Today is all around achieving outstanding medication audits, and I'm going to hand straight over to our guest presenters this afternoon, Sultana Pasha and Harel Kodavayas from Manor Group Consulting. Sultana, over to you.
Thank you, Liz. Yes, my name is Sultana Pasha, and my colleague Hiril today will be speaking to you about medication best practice. One of the key things for CQC, and what some of you may know, is CQC is currently really focusing on medication optimization. And a lot of services nowadays are having pharmacists enter their homes in order to support the inspectors with the inspection, and specifically around SAFE. So I thought that it would be a really good opportunity to bring Hiril in. She is a specialist in her field. She is a pharmacist as well. She has supported me with many inspections as well. So I'll hand you over to Hiril, and she will hopefully give you some really good insight into how to get the most out of your inspection when it comes to medication. Over to you, Hiril.
Thank you, Sultana, and thank you, Elizabeth. So hi everyone. I'm Hiril. I've got a care homes background for about 15 years. So I've been working in health and social care about 15 years. I've had various roles with care home pharmacy teams in the ICBs, including Central London, Hertfordshire, and many localities. But I've also worked with private care home groups, supporting them with their medicines management and taken through them through their CQC inspections. And we've had many with outstanding results as well. So today I'm just going to take you through medicines management. A lot to cover in the topic, so I will try my best to cover as much as I can in the time given. I'm just going to share my slides. Can everyone see? Can you see me? Yeah. Okay. So as I said, there's a lot to cover, but we will be focusing on a few themes today. So first one is robust record keeping. So the importance of accurate real-time documentation, and including how to manage and clearly explain any omissions. We'll be looking at staff competencies, so how to embed a strong medication framework through training, observations and assessments. And then we'll be looking at audits and actions, how we can proactively drive improvements and evidence learning. And we'll learn that all three of these go hand in hand, and how they work together to give good sort of medicines management. So as we all know, CQC look at 5 key areas: so safe, effective, caring, responsive, and well led. So under safe, we've got the quality statement of medicines optimization, where we make sure that medicines are treated and meet people's needs and capacities, and enabling them to be involved in planning, etc. But medicines do fall into all the other categories as well. So although medicines optimization sits at safe, it does feed into effective, caring, responsive, and well-led. So for example, for effective, assessing needs comes in there, where we're looking at self-administration and delivering evidence-based care and treatment. So are we in line with NICE guidelines and best practice guidelines, and following local guidance? What do your local ICB policies say? It looks at monitoring and improving outcomes. So if you've got residents that are on pain, how are we monitoring and managing their pain, for example? It looks at consent and care. So looking at best interest decisions, etc. Also caring, kindness, compassion, and dignity. So are we treating medicines? Are residents being given in where we're taking into consideration their dignity? Like, is it in a open area, or is it in their rooms for certain sort of treatments? Are we giving them independence and choice? So, for example, are we giving them access to non-prescribed medicines, for example? Are we promoting independence and with medicines administration, etc.? So, and then responsive, again, person-centered care is where responsive falls in. Are we giving person-centered care in line with medication management? Are we providing information? So this is where, you know, our transfer of care documentation, where residents are being transferred between hospitals, home, other care settings. Are we providing the correct information when it comes to the medicines management? Because as we all know, this is where most of the medicines errors happen. And then well-led is all about our governance, management, and sustainability. So do we have a strong governance structure for medication? Is it a part of our monthly and weekly governance of meetings, etc.? So it does feed in everywhere, although although the main, you know, the actual quality statements is within SAFE. So these are the main areas which you will be inspected on, you know, which are really key in your auditing as well. So we will keep referring back to the slide in this presentation. So you know, when it comes to record keeping competencies and auditing, I think all these areas form a really key part. So if we move on to record keeping, and so for example, medicines policies and signature records, really important to have your signature records so you can track signatures in CD books, etc. If you've got errors happening, you're aware of who that signature belongs to. Observations we'll come on to in a bit. Medication administration records, so these are your MAR charts or your EMAR documents. Really important when it comes to record keeping, because you know, there shouldn't be any gaps. Everything should be accounted for. We need to, if there are any exceptions used, we need to explain them thoroughly, and this is where we get a strong sort of medicines management process. Again, with ordering, receipt, and storage of medicines, are we in terms of our record keeping and documentation, are our fridge and room temperature records complete? Are we doing checks on those? Are we getting our prescription tokens, and are we keeping them, etc.? Medicines waste, so your disposal logs should clearly explain what you're disposing and the reason, and this can lead to many sort of things. Number one, is our waste appropriate or is it inappropriate? And this is where we do sort of get checked up upon. When required medicines, are our PR and protocols up to date? Are they person-centered? More importantly, you know, are we giving medicines in line with that residence requirements in terms of PRNs? And then are we doing follow-ups? You know, and we need to record the outcome of the follow-up. Was the PRN effective? Controlled drugs, so as we all know, our controlled drugs register is a legal document. So everything recorded in there, it needs to be in line with the policies and guidelines. Any errors in a CD CD book, for example, you cannot cross out because you're tampering with a legal document, and it could indicate tampering if you're crossing anything out. So, you know, there are ways around it. You can bracket it and then asterisk it and explain what the correct entry should be. High-risk drugs and care plans, I could probably do a whole day presentation on this, but it's about your documentation for example, your medicines that require monitoring, like warfarin, theophylline, lithium, where they work under narrow ranges, and you know, your team need to be aware of what the signs of toxicity are, and what are the signs if the levels are too low and the medicine's not effective. Again, into the care plans related to medicine. So your epilepsy care plan, for example, a resident that's having seizures should be very clear. It should have a really clear treatment plan. If they're on rescue medicines, at what point do you give the rescue medicine? At what point do you give the second dose? And at what point do you call emergency services or or the GP, etc. I mean, so when that was epilepsy, but you've got diabetes, you've got anticoagulants, you've got cytotoxic medicines, you've got Parkinson's medication, time-specific inhaler management, sort of any inhalers. So all of these require specific care plans, and the documentation needs to be really there needs to be a clear plan for each resident that's individual for that resident, and your team should know how to treat that resident in the case of an event.
Hero, can I just interject a moment? Apologies. We've had a message in the chat regarding how this applies to domiciliary care. Will you be covering that?
A lot of this does link to domiciliary care. So a lot of this will be aligned with dom care as well. So there might be a few areas where it might not apply, but I think the majority of the presentation will cover dom care as well.
Thank you.
Yeah. Medication risk assessments. So this includes your self-administration risk assessments, your covert. If your residents has swallowing difficulties, for example, and they need to have medicines in an altered format, or if they're on PEG, if it's in a care home environment, and also if they're on non-prescribed medicines, you have to have really clear documentation for all these areas, not just in the risk assessment, but also on your MAR chart. A classic example is if your resident's on a thickener, for example, you might need to give your medication in an altered format. You might need to give it in liquid form or in a tablet form, and you might need to mix that with a thickener in line with the pharmacy and GP advice. We can never make those decisions in the care home environment or in the health and social care, so if in the other settings. It has to come from the GP and pharmacist, but that advice has to be clear in the care plan, in the risk assessment, and on the MAR chart as well. So really important, it's not missed off the MAR chart. I'll give you a classic example. If you've got a resident, say, on a thickener, they're on crush medicines or liquid medicines, you have a team member, a staff member that cancels their shift at night, and you have to get a bank nurse or a agency staff in. They come, they haven't had time to read the care plan, but they come and administer the medicines as per the MAR chart. Now you've got your atorvastatin due at night, but all it says one to be taken daily. It doesn't say anywhere to mix with the thickener and crush, and the staff hasn't read the care plan. They've just walked in. They're going to give that atorvastatin as a tablet. Residents high risk of choking. It's not mixed with a thickener, and there could be a potential choking episode in your facility. So really important that all the information is triangulated. So it's in your risk assessment, it's in your care plan, but it has to be on the MAR chart, and that is where we need to work with the GP and pharmacists to make sure that information's in the on the prescription, and therefore in the MAR chart. Homely remedies, again, you need to document when you give them, and you have to have authorization forms in place for each resident individual, which has to be agreed by the GP. You cannot give a homely remedy if that's not in place, the authorization. For example, a resident might be on you might want to give paracetamol from homely remedies. They might be under 50 kilos. So when your GP signs that authorization form, they will say that you can only give one. If you don't have that authorization, if you don't get that advice from the GP, you could potentially give an overdose. So yeah, really important to have all the paperwork in place for that too. Oxygen, you need your risk assessments in place. And detailed care plans outlining everything for that process. Record keeping, what it means here is your record keeping at transfer of care, for example, when they're going residents that are discharged are admitted to hospital, what records are we communicating to them when they come back to our facilities, you know, how we what information are we getting back when they get transferred to another care home or go back home, what records are we giving. And then of course when we have our GP visits or any other healthcare professionals visiting, how are we documenting all of that, because that is really key in ensuring medicines are safe. Medicines are reconciliation, a massive sort of area, and it is on CQC's agenda. It's on their website and they are looking at this, but medicines reconciliation is really important because it is where a lot of the errors happen. So what medicines reconciliation means is that when, for example, a resident newly gets admitted into our facility, how are we making sure that list of medicines is the correct list? Or if they're discharged back from hospital, how are we making sure that list is the correct list? Often there's a whole process of doing this, and this could be another hour's sort of presentation, but it's really key, and it's really key that you have processes in place for reconciling the medications for residents. Equality and diversity, we won't touch on as much, but it could be that, you know, cultural needs, what you're doing for residents that are on a vegan diet and how you're facilitating the medication administration. If they're on capsules, for example, can we change them to tablets where, you know, because capsules have gelatin in them, you know, that's just an example. There's loads of other things we can look at. Medication review and polypharmacy reviews, we need to document them. If our policy says 6 monthly, we need to evidence 6 monthly reviews, hence why documentation is really key here, because we need to evidence what you know, we're working in line with our policy. Medication errors, adverse effects and safety alerts, again, we need a clear sort of documentation records of our errors, and then, you know, our actions following it, what we did, what our lessons learned process was, and how we managed that error in the care home. Training and development we'll touch on when we do the competencies. Stock checks, we need to evidence that we're doing them and the outcomes. Nutrition and hydration I sort of touched on when we talked about the thickeners, and then audits we'll go into in a bit later as well. So yeah, just to sort of highlight the importance of record keeping in medicines administration. So number one, record keeping must when we're doing our medication administration rounds, recording must be at the point of care. We must never sign retrospectively, so it has to be at the time of administration. So not 10 minutes later, not half an hour later, not 5-10 minutes before. You know, as soon as we're given the medication, that's when we sign it. If you do retrospectively sign, there's lots and lots of risks. There could be risks of double entries. You won't get an accurate time stamp of the time you gave that medication if you're on email system, and it can lead to a lot of errors. And when there is errors and you're trying to then trail back what happened, if you've not recorded at the point of care, that's going to open another whole can of worms. So really important that recording at the point of care is vital, even with whether that's with creams or any other formulations linked to medication. Time-specific medicines. So for example, for Parkinson's, Parkinson's UK do state that medicines for Parkinson's have to be given with a half an hour window, so ideally 15 minutes before, 15 minutes after. What I normally suggest to care homes or other facilities is put in alarms. You know, put in an alarm 15 minutes before it's due, then you're guaranteed to administer that medication at the time it's around the time it's scheduled for. Parkinson's UK have lots of resources that have get it on time stickers and loads of other things you can implement to make sure that we're giving those medicines on time and recording on time. Other sort of areas are things like insulin that you know might be more time specific. alendronic acid, antibiotics have to be given at certain times, and that this is where record keeping is really important. So if you've got an antibiotic that was due an hour before food, you need to evidence that you gave it an hour before food. So, you know, if they had breakfast at 9, you need to evidence that you gave it at 8. Often when I go and do audits, you know, it was given at 9 and they were having breakfast, you know, around that time, which means that antibiotic's not going to be effective because it works better on an empty stomach, interacts with food, for example. Clear explanations of gaps and omissions. So if you've got, if there is gaps, please explain them or encourage your team to explain them, especially when you use the other exception code. Other means it doesn't mean anything for anyone sort of looking at that MAR chart. Explain what other means, what happened, exactly what happened. Even if it's late, so if you're giving a Parkinson's medicine, then you put in an exception code as administered late, then explain it, because actually just by putting late, you're actually making yourself a non-compliant because you've given it late. But if you explain it, maybe say K-carbidopa was due at 11. We tried administering at 11, but resident refused. We tried again at 11:15, resident refused. At 11:30, we tried a different team member, and we offered a different drink. They still refused. You know, it shows you that, you know, you tried what you could, and actually it was, and then eventually at 11:45 or at 12 o'clock, the resident accepted it in the presence of their family member there. Then it's showing that actually, yeah, you gave it 1 hour late, but everything you tried in that time, it's justified. So really, really important to sort of explain any gaps or omissions. And again, for refusals, the same thing, explain the refusal. What did you do? How many times did you try again? Resident does have a right to refuse, but if it's, for example, an anticoagulant, are you going to say you're going to try once, they refused, and that's it, you're just going to put refusal code? Because actually, if you omit a critical medication like warfarin or an insulin, it could have an adverse event. It could have not so nice sort of consequences. So, you know, what have you done to make sure that, okay, you've tried again, you've tried a different team member, you tried at a different point in time, and then they were still refusing, and then you put your refusal code in. Body maps, really, really important. We must have clear, so especially for patches or insulin, we must have body maps in place that that explain where medicines were, where that medication was administered. So, for example, if it was a rivastigmine patch is a classic example, which gets inspected all the time. Rivastigmine patches have to be rotated have to be changed every day, and the site of administration has to be rotated over 14 days. So you cannot use the same site for 14 days. So you need to evidence that you've used 14 different sites. PRNs, again, we need to have really clear protocols. We need to do follow-ups. We need to see if they're effective. Homely remedies, again, we've spoken about the documentation, and accountability is key. So when we move on to auditing, we'll go back to the slide because these are all the areas we need to audit when we carry out our audits. But that does not mean we do all the areas in one go. Think about your auditing process. Do what works for you. You might have some daily audits where you're, you know, you might be just looking at your CD book, your fridge temperatures, etc. Then you might have some weekly audits, which might be your stock count audits. You might have some bi-weekly audits like your clinical room sort of audit. You might have your main medicines management audit where it looks at just the key areas of medicines management. Then you might have a more specific audits, which you can do every 2 months or 3 months, like where you look at all your risk assessments or where you look at your competencies, for example. And then the quarterly, 6 monthly, and yearly would be more linked to your inspections, your pharmacy audits, your ICB audits. If you've got a head office team, they might come in and do checks, or you as management might do sort of quarterly audits and overall audits. So just look at your process in terms of what works for you. In my previous organization, I set up bi-monthly audits for certain specific areas, so they weren't looking at the risk assessments every month, because it can get then it just becomes a tick box exercise. So I think that last point there, quality over quantity, is vital when it comes to auditing. Don't over audit and then it becomes a tick box exercise. Look at what works for your organization and schedule your audits in such that each audit is a quality audit, and you're picking up things, and you're completing the auditing cycle. So you're picking up an action and then you're working on it, and you're evidencing your learning, and you're driving improvement. So any themes you're addressing in the audit. Just moving on to training and competencies. So just some stats here. So 85% of UK providers use e-learning as a part of mandatory training. Only 47% consistently combine e-learning with practical observations or mentoring. Face-to-face training showed a 65% higher retention rate for practical procedures compared to e-learning. In care homes, using face-to-face medication training with follow-up competency checks has reduced errors by up to 58%. That's some figures from Scotland. And staff confidence in applying new skills was 30% higher when training included an interactive or in-person component. So really think about how your medication training is structured internally. If you're just relying on e-learning, sometimes that's not the best. I mean, e-learning is effective, but if you're solely relying on it, you need to think about is that effective for your workforce. Think about who you're targeting, and if you need the face-to-face, and I think with medicines, face-to-face element is really important. So training and competencies, they're really important because it does safeguard our residents, it promotes compliance, it really increases staff confidence and accountability, it contributes to person-centered care, it improves audit outcomes and continuous improvement, and early identifies any training needs in the process, and it gives consistency across team shifts, and it protects your staff as well. I think the key with training and competencies is, again, quality over a tick box exercise. So making sure that we are doing quality competency training and competency checks. It's not just your annual competencies you have to tick. We do need to make sure that we're focusing on quality. So for example, this is part one of my competency assessments. If you're observing someone giving creams, you might just observe them giving a emollient, but then do a verbal competency with them on other areas. So if you're applying a steroid cream, how would you apply it? They need to be aware that it has to only be applied thinly. If you were applying cream to a very hairy area, how do you do it? They need to be aware that it needs to be applied at the direction of the hair growth, otherwise it can be very painful for the resident, especially if they've got fragile skin. So I am conscious of time, so I will move on. So yeah, just to sort of sum up, we've got all our key areas that we look at, but I think auditing, competency, and record keeping, I think they all go hand in hand. And if you've got good record keeping, audits will pick up competencies and record keeping, but all three elements are key in good medicines management. So any questions? Sorry, there's a lot to cover in half an hour. I tried my best. So
I think I'd like to just add with regards to the domiciliary side of things. So a lot of what Hyrule has said does imply to dom care. We just have to think of it slightly differently, because within the dom care setting, people will refuse, and you might only, we had a chat going on that, you know, you only go in once a day, and if somebody's refusing, the key thing is for CQC is you need to be documenting the actions that you are taking. If somebody's not taking their medication, who have you told about it? It's not a case of every day it's being recorded as not given or refused or unable to give them or anything, and they've gone a whole week without having a certain medication. It's about you documented. Have you raised it with the GP? Have you spoken to the family? What other areas have you looked at in order to support the person? Because it is slightly different in dom care than in care homes, because obviously you might only be going in once a day for half an hour, a quick half an hour call. So it's very different. But hopefully I've been able to answer some of the questions in the chat as well for you.
Thank you, Sultana. I was going to say, have everyone who's put the questions in the chat, have you all had a response, or is there anything you still want to ask while we've got Sultana and Hyrule on the call? No? Okay,
No.
thank you. Nothing at the moment. So what will happen, we are preparing a resource pack for you, so you will have a recording of this session, all the links to the guidance that has been referenced, the NICE guidance and all the CQC standards, together with some hints and tips and some support documents. So if you've been forwarded this link, not through the registration, make sure we've got your email in the chat so that you can receive the resource pack. And thank you, Sultana and Hyrule, for tackling a very big subject in half an hour. It was a great, thorough run through, really valuable use of time. Thank you very much. And again, we will be on the call for a couple of minutes if anybody does want to just stay on and ask another question. I'm going to stop recording now.